good evening to all. So it's a wonderful topic to know about emergency medicine. Means when I started my journey in emergency medicine, say around 15 years back, it was a limited resources. Nobody knew much about emergency medicine. But thanks to Doctor for arranging such a insightful and a good topic to discuss and enlighten everyone about the roadmap for emergency medicine and building a career in the field of emergency medicine. So, moving ahead, first of all, I will like to these are certain certifications which I had got, and just to enlighten everyone how you can go ahead. But to go ahead and to begin the journey, first is the start of your career.
Thank you.
So, to continue the journey, the most important thing is the start of the journey. So, how do we start our journey in emergency medicine? How do we select emergency medicine as a career for us to pursue? So, first you have to know your interest because this is something that will keep our lifetime. So, to select a particular field, you should know whether you are interested in the field of emergency medicine or not. Now, where do you get the taste of emergency medicine? The taste of emergency medicine or the first exposure of emergency medicine comes in the internship itself that we often miss out. That is the casualty posting. Casualty in the previous world is now the emergency department of today's world. So you should be having an interest in acute, undifferentiated patients. Acute, what does it mean? So acute is something very acute, very something very sudden. It can be an acute pain, which may be because of the gallbladder, maybe because of the gastritis, maybe a stone, anything. So anything acute, it may be a fever, high grade fever, 104 degrees Celsius. Undifferentiated patient. Like it is very difficult to differentiate a patient whether we should go to the medicine branch or the surgical branch. There can be overlapping, or there is something undiagnosed that makes you curious about the patient and the treatment. So that is something, the essence and the means you should get interest into it to select the field of emergency medicine. Now, next comes build a strong ABC approach. Emergency medicine, if you treat, it's very simple. It is very basic. It's like a flow chart, 1, 2, 3. You have to go through the guidelines and you have to proceed further. So ABC is the mantra of emergency medicine treatment. That is the airway, breathing, and circulation. We always take care of the ABC of the patient and then proceed further to save the or to treat the life-threatening emergency. Now, how can we go ahead with emergency medicine? What are the options we have? We'll deal in details, but what just to give you an idea, be a MD, it can be a DNB emergency medicine, or it can be a MEM pathway, that is a Master's in Emergency Medicine pathway, or you can opt for fellowships, which I have shown in the previous slide. So emergency medicine is all about a fast-paced decision making. You have to be very quick. The decision should be from your spinal level. It is not that you will get all the reports, you will have the lab results, and you have much time to consult the books and to think. It is the need of the hour. On the spot, immediately at the ground level, you have to decide what needs to be done immediately for the patient. That is the impact and that is the decision making in the golden hour. Once you see the timeline behind, you may think, oh, I have lost a lot of time, which is not permissible in the field of emergency medicine. You have to be very quick because your quick thinking, your rapid decision making can be life-saving for someone. So how do we know, okay, I have done my casualty posting, it was okay, it did well. I'm not sure if I need to opt emergency medicine as my career. Keep visiting the casualty, keep visiting the emergency department of your hospital, do some duty, see more patients, and then you can come to know whether you are really interested into the emergency medicine. Because in emergency medicine, if you are interested, acute patient, an acute trauma patient makes sense. So the career pathway emergency medicine can be MD emergency medicine, which you can go through need PG entrance examination. Also, you can opt for DNB emergency medicine, which is there in the private hospitals, which gives you a better emergency department to practice. I should MEM programs like Society for Emergency Medicine India, George Washington University, they run the MEM programs in the country. These are Masters in Emergency Medicine programs which are not recognized by the Medical Council of India, but they are very much valued in the private sector. Other than that, there are fellowships, which is a 1 year course, fellowship in emergency medicine, which gives you a taste of emergency medicine, and then you can go and master the emergency medicine by MEM. Also, there is a pathway known as MRCEM, that is a member of Royal College of Emergency Medicine. It is something very similar to what we know since ages, that is the MRCP. MRCP is for physicians like medicine trainees. MRCEM, it is for specialized for emergency medicine by Royal College, and the course is there organized by Royal College of Emergency Medicine. It is a three-stage program like part one, part two, and part three. Part one is the paraclinical courses. It's a written exam, multiple choice questions, which you can give in India or abroad. Part B again is a detailed theoretical examination, again MCQ based, for which you need 2 years of training in emergency medicine. And then part C, which comes the practical exam or the OSCE, for which you should have completed 3 years of training in emergency medicine and under a trained consultant. And then you can get the MRCM degree, which is recognized in few of the sectors of the country. All these three exams can be given in the country itself. So what it takes to grow, you can have MD, DNB, MEM, or MRCM. But to sharpen your skills, to know more about emergency medicine, you can go ahead with certain certifications like BLS, ACLS, ATLS, PALS, NELS. All these are life support courses which are there by the American Heart Association. ATLS is by the American College of Surgeons. It is a advanced trauma life support course. ACLS is advanced cardiac life support course, and NELS is about the neonatal advanced life support course. So these are the certifications which make you practice again and again, so that it comes at your spinal level, that you, even in sleep, if somebody asks you, you are able to reply them without even thinking about it. So this is to make you train harder and harder, again and again, to sharpen your skills, to make the decisions quickly in the need of hour. So that trains you for decision making under pressure, and also trains you for communication and leadership. It is one of the most important aspects of emergency medicine. Emergency medicine, what I have talked so far is about the clinical setting, about the knowledge, the skills. But one more important skill is communication and leadership. You have to work as a team. Emergency cannot be dependent upon a single person. The department cannot be run by a single leader. Once a leader, you have to have your team. It's a trauma team. It's an emergency team which comes into play. The team starts from the very first moment when the patient is received by the crew member or the security guard. They just roll in the patient inside your emergency department. Then comes the triage. The triage nurse gets triage, checks the vitals of the patient, alerts you if anything serious is there. Then the nursing care, the doctor, the radiology, the patient needs to be shifted to the cath lab. So everything comes in a full package. It's a teamwork. You cannot do anything alone for the patient. So you have to be a good leader to have a good emergency team. Communication is also equally important with the colleagues, definitely, but also with the relatives. When you counsel the relatives about the acuteness or the severity of the disease, you have to be both calm, as well as you have to explain them in simple language so that they can understand. And also you have to be confident enough so that they can believe in you. I'll just give you a small example to understand communication much better. Say a person has come to your emergency department with a complaint of chest discomfort. and you do an ECG and find out that it's an ST elevation MR. Now, when you call the relatives and say that the patient needs to undergo an angiography and angioplasty, the relatives will be shocked. No, it cannot happen. He does not have any chest pain. Maybe the patient just has a chest discomfort, or maybe he's a diabetic without any chest pain, just uneasiness. So it will be very difficult for them to believe that it's a heart attack. Now, you cannot proceed with the treatment against the patient's will. If you let this patient go, definitely you are fine. The patient can sign the bond and go away. But we are here to serve the community. We have to make them believe in us so that we can give better care to our patients. So there lies the importance of communication to explain them. Another example for communication is a patient has expired in your emergency department. Now this, breaking the bad news to the patient relatives, a son, the daughter, the wife, or the husband, that your patient has expired with no more. Say a case of broad dead in emergency. These are something very difficult communication stations which we have to learn. We have to practice day in and day out so that we can be good leaders and good emergency physicians. Now, clinical learning. If I talk about emergency medicine clinical learning, it is all about sticking to your basics. Something that we have learned in our internship, the final year, the very basics, the clinical examination, the history taking and the clinical examination, because that's all we have in the emergency department. The patient has not got any investigation results. If you send the investigation, it will take hours, few hours for the results to come over. So we cannot wait or for the decision making till then. So it is all about your skills, your clinical examination and the history taking, based on which you will make a provisional diagnosis and make a plan of management for the patient. We must be the masters of airway, breathing, and circulation. We should know our protocol, how to go ahead. Core areas which we get the life-threatening cases normally are the trauma patients. It can be a polytrauma with an abdominal injury, head injury, orthopedic musculoskeletal injury like fracture, cardiology like heart failure, heart attack patients, sepsis, very important, and acute stroke. These are certain conditions in which we have to act really fast. Procedures which should be well known to an emergency physician are like intubation, placement of a central venous access, an arterial line, intercostal chest drain, and must be good enough to do a fast scan using ultrasound bedside. Protocol-based management for life-threatening scenarios, which will be based on the guidelines as per the ATLS, ACLS, NALS, and PALS. So the tip which is given here is focus on pattern recognition. That is what we normally called as experience. The emergency physician, somebody who is trained enough, will be able to identify with the complaints or will be able to sense that there is something wrong with the patient is sick looking, something serious is going on with the patient. That is how we do it. And that comes with experience and the more and more patients we see in the emergency department. Personal development, definitely communication with the relatives in crisis, that is very important. It may be crisis related to the clinical condition of the patient. It may be the financial aspect of the treatment, which is there to be explained to the relative. Stress and burnout management. Yes, emergency physicians get burned out very quickly because of the immense amount of pressure which they have to deal both with the patients, the colleagues, and the relatives. Also, the hospital management. So a lot of stress goes on. Emergency department is just like a mini hospital running on its own. So a lot of stress is there. You have to take care of your colleagues. You have to take care of yourself of how to handle this stress. And leadership in chaotic situations. See, chaotic situations, it can be so much chaotic, like a road traffic accident with a car accident, around 6 relatives which have got injured, polytrauma. They have been rolled in your emergency department. But these are not the 6 people only. With them, there will be somebody who is bringing the patients into your emergency department from the roadside. There will be police who will be there for their investigation. There will be the relatives of these 6 individuals. A lot of public is there to handle. And that is what a good leader has to cater and handle all this in this crisis situation. Emotional intelligence. Everybody is emotional. Even we emergency physicians are emotional. We feel bad if somebody is very critical or dying in front of us. There is nothing much we can do but try our best and hold on our emotions. We cannot be like, uh, we have to control our emotions. In the flow of emotions, we cannot take any decisions based on this emotion. It has to be as per the guidelines. It has to be as per the clinical science. We cannot just take any emotional decision on the field, on the emergency department, on the floor. Strategic move is whether to choose MD or DNB or MEM. Which one to choose? Choosing between MD, DNB, and MEM is the trick, or something a very strategic move, as it is mentioned here. Because MD and DNB, as we know, are recognized by the National Medical Council or the NMC or the previous MCI, whereas MEM is not recognized, but it's equally important and well featured in the private sector, in the private hospital. But what makes it more important, the MEM, is there is exposure, good amount of exposure in the private sector, in the private hospital. MD is done in the government sector. So there you have to choose the hospital, you have to choose the degree based on the faculty, because those are the ones who will be teaching you, who will be giving you the exposure to the emergency medicine. Build your CV early. You have to have a good resume. You have to have a number of researches. You should attend a number of conferences to build up your CV. Get as much certifications as possible, like ACLS, ATLS, and PALS. Have a good networking and mentorship. As I say, mentorship, there comes the role of the faculty or the teachers who are going to teach you. The faculties are very important that will mentor you, guide you through your journey of emergency medicine, and help you networking, means meet new people, those who are working around in the country and abroad in the field of emergency medicine. It's better to have a high volume ER, means the number of footfall in the emergency department is very important. It should be a fair number of patients and variety of patients. If it's a multi-specialty hospital with a variety of patients, that's even better. What are the common challenges that we face in emergency? Undifferentiated patients? Yes. Most of the patients presenting to you are undiagnosed. We don't know what is the diagnosis. There can be overlapping systems that makes it much more difficult to decide how to go ahead. Time critical decisions. Anything based on time. It's like acute stroke, ischemic stroke, when to thrombolize, what is the window, whether we should go ahead or not. STEMI, you have to maintain door to needle or door to balloon based on the availability of the treatment options you have. So these time critical decisions makes it very important, and you have to be very fast in decision making. Overcrowding, definitely we have to manage. You have to have your crowding policy in the department. With the limited resources which you have to manage the patients which are there in your ER. Night shifts and irregular lifestyle definitely affect the mental state and the physical state of the patient. Day duty or night duty. It keeps shifting. Maybe 2 days, 2 nights, maybe 3 nights, one day. It's a shift-based duty in the emergency department. Apart from that, you have the medico-legal pressure. Once you do an MNC, you may be called, you may be summoned in the court. So that is something you have to handle very smartly. You have to be very strong in your documentation when you are documenting any case report or any patient. Handling aggressive attendants. Yes, there comes aggressive attendants. We all know in the country that there are many cases of violence against the doctors. So there are attendants who can get aggressive. Now, how to make them calm or how to explain them and when to call for help. All these are very important and tricky that we need to be trained in. Emotional fatigue, something that may or may not affect you because you have to be strong enough. The adrenaline should be running strongly in you once you are on the floor of the ER department. So you have to be very strong, not only physically, but also mentally to handle the pressure in the emergency department. So my advice to the young doctors just cleared MBBS, master the basics, that is the ABC, airway, breathing, and circulation. Be the master of it. Reassess the patients frequently. A patient, what you have seen now, may not be the same or may not have the same vitals or the complaints half an hour later. It may be changing. The patient is not bleeding now, maybe has started bleeding an hour later. The blood pressure is now 120 by 80. It may be not recordable after half an hour. So patients' vitals, the scenarios keep changing. You have to keep reassessing the patient as frequently as possible. Be clinically strong in the basics, very basics, like history taking and physical examination. Clinical examination is very important. Don't ignore the vitals and also the complaints by the patient. Don't say it's a vague complaint. Anything coming from the patient is very important. You have to give a strong head to it. Ask for help early. Don't try to be heroes because we are dealing with someone's life. Not able to intubate once, check for help. Call the anesthesia. Go for help early because we are dealing with someone's life. We have to save the life. Practice procedures repeatedly so that you master it. But still, one can fail in any procedure and whenever needed, call for help. Maintain humility and curiosity. We must be curious. We must follow up the cases, what is coming on, so that the next time the patient comes with the similar pattern, we know what is there with the patient or what's happening with our patient. Find a good mentor, something very, very important that will take you ahead in the journey of emergency medicine. Mistakes, we all do mistakes, and that is how we learn. But at the same time, we have to learn from the mistakes which have already been made by someone else so that we don't commit the same mistake. So never ignore the vitals or the ABC approach. Stick to it. Stick to the basics. Be quick in decision making field of emergency medicine. Documenting, not documented is not done. If you have done it, you have to document it. Don't go for over investigation. Investigations have to be very basic and patient oriented. Whatever you are thinking, it should be based on that so that it guides you through the treatment. Reassessment must be done and should be done frequently because the patient and the scenario keeps changing. It may not be same what is now. If I compare the consultant level, like what is an average emergency physician and what is a consultant level emergency physician. So consultant levels are those who are senior in the field of emergency medicine. They know the importance of prioritization, the triage, which one needs to be addressed first. They are a good leader. They know how to take your team together to treat the patient and run a smooth emergency department. Anticipates the complications. Somebody who knows or can feel with the patient that something is wrong with the patient. And efficient patient flow. Patient flow is not only about inflow. You have to manage as a leader, as a consultant, you have to manage the outflow also. Say you have 10 beds in emergency, you are just receiving the patient. You're not moving them timely. There is a lot of length of stay in emergency department is very high. You will be stuck. All your 10 beds will be filled up and you will have start waiting outside the emergency department. So you have to maintain the inflow as well as the outflow of the patient. You cannot just keep patients in emergency for long duration. There can be various things which can change the life of a doctor, of an emergency physician, obviously, like missing an MI, heart attack in a young patient. If you save a polytrauma patient, that gives you a good feel, confidence to treat the next trauma patient with confidence and with good care. Pediatric emergency, once handled, will give you so much of good feeling and confidence that you will be ways much ahead in your patient care. So never ignore the red flags. Red flags is something that is alarming. You have to know it must be addressed immediately. Trust the clinical judgment. Don't go by the investigations alone. Investigations sometimes can be misleading, sometimes can be delayed. And know the importance of teamwork. Without team, you cannot run a smooth emergency department or provide a good patient care. Now, talking about the scope of emergency medicine, healthcare in India is growing very fast. And post COVID, everybody has realized the importance of emergency department and emergency physician, both in the government sector and the corporate sector. There are multiple opportunities which are there, not only in India, but also abroad. There is always a demand of emergency physicians around the world. All the departments, all the hospitals are setting up new emergency departments, or those who had emergency department are expanding the emergency department. Even accreditations like JCI, NABS mandate the requirement of emergency department and minimum number of beds in the hospital to have a NABS certification. So there lies the importance of emergency department, and management has realized it. So the opportunities are numerous, not only at the junior level, also at the senior level, like the consultant, junior consultant level, associate consultant level, multiple opportunities. Since the opportunities are more, the demand is more, even the pay is good. Definitely, it varies at the level which you are joining and the city in which you are joining. But yes, it's at par with the market and giving good salaries with a good increase. So since it was something to enlighten about the emergency medicine, I have talked from my end what I thought should be known to you. But you're all open to have questions and know, ask questions about emergency medicine or any doubts you have how to proceed with the field of emergency medicine.
Thank you, sir. This was actually a very clear and structured and insightful session because your breakdown of career pathways, fellowship opportunities, that required skill sets and real world growth prospects in emergency medicine was extremely valuable. And this session, I'm sure, has given our audience a much needed clarity and a direction to make informed, career decisions. Now, yes, we have questions. Since you mentioned of the Q&A session, there are a few questions that has been, in the chat section proposed. I'm going to read out one by one. So we have a question to begin with. How to choose between MD versus DNB versus MEM? What is the strategy?
See, as I told, that is a very critical decision to make whether you have to go with the MD, DNB, or MEM. First, you have to know whether you want to serve in the government sector or the private sector, whether you are affected by whether your degree is approved or accredited by the NMC or not. If you are very much concerned about it, you can go ahead with the MD or DNB, because MEM is something which is not recognized by the NMC. Now, choosing between MD and DNB, both are absolutely equivalent. All lies in which hospital you are there, what are the facilities provided in the emergency department of the hospital you are going to join. Say, if I give you two examples, roughly, without no offense against any of these, say a government hospital with an emergency department, which has not got any quick access to the CT scan or the ultrasound. Whereas there is a private hospital which offers DNB, which has got just a second order CT scan, MRI. There is a USG machine in the department itself. There is a video laryngoscope and a good equivalent mentor in both the situations. So I will definitely suggest you to go for the DNB because you will have much more exposure to the technology and the resources. And if the faculty is much more important, you can choose based on the faculty also. So it's the resources, it's the hospital, the number of patients or the flow in the ER and the mentor, definitely. These are certain things which can affect your decision making while choosing between MD and DNB. Coming to the MEM, it's a private sector course, easy to get in, 3 years course, definitely with a good structured training in the private hospitals, giving you a good networking and well recognized in the private sector. So based on these characteristics, you can make a decision which one to join.
I think that was a very valuable advice because, like you rightly mentioned, it was a very crucial decision, and one has to factor in a lot of things before they decide what they really want to do. On a similar note, is the next question here. It says Dr. Manu has a question that reads, career aspects after MRCM and private setup at junior consultant level. He'd like to understand the salary and progression as well.
See, after doing any degree in emergency medicine, say you have mentioned about MRCEM. Once you cleared MRCM, you are at the consultant level. But it's not always the degree which matters. Yes, you are at the consultant level, which may be a junior consultant, associate consultant, or the senior consultant. But it always based on the experience and your skills and decision making, which is important. Now, salary, if I say anything of for a junior consultant in emergency medicine will start from around any of the cities. Minimum salary will be somewhere around 1.2 to 1.5 to start with. Rest all depends upon the city where you are joining and the hospital in which you are joining.
Moving ahead, the next question is MEM certification valid anywhere outside India?
No. MEM certification is not valid or taken as a degree outside the country. They will regard it as a 3 year training in emergency medicine, but not as a degree.
There's another question. What are the opportunities available abroad?
See, there are multiple opportunities. Once you clear the MRCEM, that is the pathway to go outside. Because if you do MD or DNB also, then you have to clear the foreign entrance examination for the country. But after clearing MRCEM, you have a direct entry to UK. You don't have to give any PLAB. You don't have to give any other entrance examination to enter the country. You have a direct entry to UK and many other allied countries. Job opportunities are good. You can have a starting salary of around 6,000 or more pounds per month. So it's a good, you can get directly at the registrar level or ST3, ST4 level once you clear MRCM in India.
No, it's all. Also, one question, I have this here out of curiosity because, since I understand the kind of experience you carry, and I'm sure the audience here would also want to understand and hear from you. Has there been a case that has changed your clinical practice permanently? Is there any case of that kind that you can share with us?
See, it is not a particular case which I can say. I have experienced many cases, not a single one, but yes, many cases. I will just give an example of a road traffic accident, which came to means when we talk about the road traffic accident, we say it's a trimodal distribution of death. Death can
Right.
occur on the spot within few hours or maybe after days. This person, he was a
Mhm.
high-speed motorcycle racer who came to our emergency almost walking, taken by the fellow mates that the patient has a road traffic accident. He was just thrown away by the bike accident, speeding car. So the bike was at a speed of around 200 kilometers per hour. So it
Okay.
was a high velocity. So we got he was complaining of some chest injury. He
Mhm.
was absolutely fine. Oxygen saturation, the vitals, what we say, were absolutely stable with the proper ABC maintained. That is what I have focused on, maintaining the ABC. So we sent for the routine investigations like the X-ray and ultrasound. Just soon as the patient came from the X-ray, the patient collapsed in emergency. We tried to revive the patient. We pulled on the CPR, and as per the guidelines, we did everything. And the moment we saw the X-ray, it was a widened mediastinum. The patient had a diagnosis of aortic dissection. So this patient collapsed in front of us, and we could not do anything much for this patient. There has been similar scenarios like in MI patients, in pediatric patients after polytrauma. So there are many a times that yes, we can do something, but there is very less time for you to act,
Right.
and your decision making makes it very important for saving such patients. So even if you go by the guidelines, something which
Mhm.
is destined will happen, but we want to give our best shot and to change this. Maybe we should not, that is why I said you should not be relying on the investigations. It is your insight that should affect your decision making and your clinical examination history rather than and any such scenarios, you should always go back and see the timeline, how much time you have taken from the entry of the patient to your decision making, so that next time you are much more faster in decision making.
True, sir. Fair enough. Make actually a lot of sense because I think early detections also is a very primary procedure that one needs to be careful about. Um, Moving ahead, I have another question. It reads, has there been a point where there is a lack of autonomy, as like in other fields, you can't control your own practice. You have to work in a hospital and with a team.
Yes, there is a limitation of emergency medicine that you have to work in a team and you have to be associated with a hospital. But I will take it as an advantage rather than a disadvantage, because once you are out of the emergency department, you are free. Whereas a medicine consultant under whom, say, 10 patients are admitted, he will be getting calls from all day and night. He is not able to go on a holiday because all those 10 patients he has to hand over to someone. His follow ups of the OPD are there to be followed up. There is always a mental trauma or a tension which is going on. But an emergency physician is, once the handover has been given to your next subsequent colleague, you are free of the department. You have nothing to do. It's the stress which is there in the department itself, not beyond that. Moreover, I say emergency physicians are doctors, what the general public means. Like, if I ask a layman, what should a doctor know? They will say a doctor should know the ECG, should know how to treat the fever, should be able to diagnose the fracture looking at the X-ray, and they should know everything, like a stitching and everything. That is what an emergency doctor is. He knows all the bits and pieces, or all the first interesting hour of all the specialties, be it gynae, be it cardio, be it orthopedics, everything. A complete doctor in every sense.
Noted, sir. Moving on, I think there's a very interesting question that's been posed now. What's the main difference between critical care and emergency medicine fellowships?
See, critical care is something very different, and this is why the two specialties have been differentiated by the NMC also. Earlier, it was a combined course, but now it has been differentiated and separated in emergency medicine and critical care. Emergency medicine is at the ground level, at the base, when the patient enters to you or first meets you. It is the first hour or first few hours of the patient. Whereas critical care is all about fine tuning. You have done everything. You have diagnosed or suspected a sepsis patient. You have sent all the labs and the cultures. You have started on a prophylactic antibiotic for the patient. Now the patient, you have resuscitated with the IV fluid. The patient gets shifted to the ICU. Now it is the duty of the critical care physician to see whether the antibiotic which you have started prophylactically goes well with the patient's condition or not, matches the blood culture sensitivity report or not, whether the IVC collapsibility is there or not, whether the fluid needs to be continued or not, whether the critical markers like sodium, potassium are okay or not. In the subsequent days, whether there needs to be any escalation of the antibiotics or not. So these follow up and the fine tuning, all these things with the lab is done by the critical care. I'm not the right person to treat a ventilator associated pneumonia, but they are. But if it comes to the intubation, whether the patient needs to be intubated or not, I will make a quick decision rather than the IC critical care physician.
Makes sense. I hope that's been able to answer the question to the question that was raised here. Also, just adding on that note, since we are talking about fellowships, I'd like to inform the audience that at Doctor Academy, just an information for you to be aware of is that we offer fellowship in emergency medicine and advanced fellowship in emergency medicine programs. Both are designed to help doctors like you to develop real world clinical experience and competence and confidently handle emergency cases. Uh, just to give a little more insight about the programs for the benefit of everyone, Fellowship in Emergency Medicine is a 9 months online program and a 3 months of on-site hospital training program. It focuses on building strong clinical fundamentals, and it's ideally for doctors who want to start their journey in emergency medicine because you have a blended, learning path, if I may say so. And the other program that I'm talking about over here is the Advanced Fellowship in Emergency Medicine. It's a full hands-on clinical training in hospital settings. It's a complete 12-month on-site program. You have daily exposure to real emergency cases, intensive practical learning with senior doctors. And again, for whom is this ideal? It's ideal for any doctor who wants deep real-time emergency care experience. And both the programs obviously help you to develop confidence in patient assessment and stabilization, emergency protocols, decision making, and obviously understanding the real world clinical skills. People in this session, the audience here for you. And also, there's another question that's come from Dr. Milap, saying, it reads, I'm currently DNB first year in emergency medicine. What things I should focus on primarily and how to publish papers?
So Dr. Milap, first of all, congratulations for being a DNB, part of the emergency medicine family. Now, as you're in the first year, I will just ask you or request you to be very much focused on the basics, something like history taking and clinical examination. bedside examination of the patient. This is very important. Go through the patients which you are seeing in the emergency department regularly. Follow the pattern. Go through your theory. Make yourself strong enough to handle these cases. Now, talking about publishing the papers, it is all about publishing your experience. It is not that something needs to be extraordinary. Say you have seen 10 patients with gallstone. We have presented with different presentations. Somebody has presented with a right hypochondriac pain, somebody with a shoulder pain, somebody with gastritis. So you have diagnosed all them as gallstones. So it can be a varied presentation of the gallstone which you can publish. So anything which you are following or which you are seeing can be just jot down and get it published. You can contact multiple online. There are multiple resources where you can just help them or ask them to publish your paper, which can guide you how to write a paper also. So it can be something like an audit which you can go. It can be an interesting case. It can be a pattern or a case series which you can get published. Definitely all these needs to be published to make your CV stronger. So please go ahead. But before that, being in the first year, I will request you, stick to your basics, make yourself strong and master of ABC.
There's one more which is posted by Dr. Sparsha. I'm interested in disaster medicine. Is PG in emergency medicine good, or should I do trauma after doing the fellowships in emergency medicine, and then do the fellowship in emergency medicine?
See, trauma surgery and emergency medicine are something, yes, it's in the same room, but something very different. Doing general surgery and then going for the trauma surgery, definitely you will be a surgeon and related to emergency medicine. But if you are interested in disaster medicine, I will suggest you to go into the field of emergency medicine and have a fellowship in disaster medicine. That will make you more connected with the disaster medicine rather than the surgery which you can. So, as you are posted interested in disaster medicine, I will suggest to go with PG in emergency medicine rather than going for general surgery and then trauma surgery.
Moving ahead, there's one question, I think probably the last one for the session. Sir, I am a FMG just done with internship in India. Is this fellowship helpful for me?
Definitely, anybody who has graduated or who has completed the MBBS or equivalent and has a license to practice in India, that is a foreign medical graduate examination has been cleared, you will definitely be benefited by any of these fellowships that will give you an insightful and exposure to the patients and the field of emergency medicine and critical care. It's really helpful because just to enlighten you all, I also started my journey with the diploma in emergency medicine, which is a kind of 1 year fellowship. Then I took the master's in emergency medicine and moved ahead with the MRCM. So that is how I knew that yes, I am interested in this field and I can go ahead.
We have one more question from Dr. Saurabh Hirani. What are the other fellowship options after DNB, emergency medicine, like the one you told already, disaster medicine?
There are multiple fellowship options which you can do. Like it's not only it's like a pediatric emergency medicine. It's like disaster medicine. You can go ahead with the critical care. You can go with the infection control. You can go with the hospital management if you wish, like non-clinical subject. You can go with the quality control. So there are multiple options even after being associated with the emergency medicine. Because as I said, emergency department is like a hospital running in itself. You need to have quality control checks also. You need to have all the quality indicators needs to be there. If the infection control practices has to be there. Also, along with the clinical things like the pediatric emergency medicine, which is a very upcoming branch in the field of emergency medicine. So there are multiple fellowship options which are there and can be done.
I think for now, that's the set of questions we have. Again, to the audience here, since you've been very patient and I'm glad you had questions, but in case you have any more questions, please feel free to fill in the form. The team from Doctor Academy will get in touch with you, will provide you all the details if you'd like to understand more about the fellowships that are being offered, the credentials attached to it, the of course validity and other related. Please fill in the form with your details, and we shall get back to you with all the relevant information required. And since I understand there are no more questions, this brings us to the end of today's webinar. And before I think I say that, there's a question: how do you prepare for FR Chem? I'm doing internship. This question is raised by Ms. Pasha.
So MRCM is the membership of Royal College of Emergency Medicine. If you just open the site of RCEM, there is a detailed pathway given, the course details are given, the syllabus is given. As I told, it's a three-part examination like Part A, Part B, and Part C. You are eligible for MRCM Part A only after clearing the internship or completion of the internship. After 2 years of training in emergency medicine, you go with Part B. And once you have completed 3 years of training in emergency medicine, you can go ahead with Part C. So this 1 year, 2 year, 3 year, it means that you have to be associated with a good emergency department under the mentorship of some senior emergency physician, so that you can prepare yourself, you see a number of patients, and then you can just appear in the exam for MRCM.
I'd like to obviously, thank you, a heartfelt thank to Dr. Nishant Agarwal for sharing the valuable insights to all of us. And I think it's been a very engaging and a very interactive session. Thanks to the audience as well. And from my end, I just hope today's session has helped you all gain clarity on career pathways in emergency medicine and given a strong direction for you to understand what your next steps would be. If there's anything, again, I'm reiterating, you can just reach out to us. We will have the questions being answered. I think Dr. Nishant has been extremely patient with us throughout the session. His insights have been very valuable and very informative. So, on this note, sir, thank you once again to you, and thank you for the audience to be a part of this wonderful session. And I wish you all the very
Thank
best
you.
in your medical careers. Uh, I'd like to sign off for today. This is Harsh from Doctor Academy. Thank you, and take care of yourself.